If you're in your mid-30s, you probably think menopause is decades away, like a sudden switch that just flips when you turn 50 or 51.
Right, yeah. We're totally conditioned to expect that very distinct finish line.
Exactly. The hot flashes start, the periods stop, and you're done. But what if that biological engine actually starts sputtering and misfiring up to 10 years before that switch is ever flipped?
Well, that's the reality for millions of people. They're going through this profound physiological transition right now.
And they're blaming it on, like, stress or just getting older.
Or even autoimmune conditions, yeah. Completely unaware that they've already left the shore of their regular reproductive years.
Which is wild. So, welcome to today's deep dive for Friday, June 5th, 2026. We are talking directly to you, the learner.
You're here because you want to get past the surface level advice.
Exactly. You want the thorough, surprising facts, the actual biological mechanisms, and frankly, you want it without the patronizing oversimplifications.
We know you respect your own time, so we gathered a massive stack of clinical guidelines for this one.
Yeah, we're looking at the latest from the National Institute for Health and Care Excellence, or NACE, the British Menopause Society, the NHS.
Plus some really targeted medical articles from Alloy, Health Central, and Cared Fertility.
All to answer one highly specific, incredibly important question. What are the very first signs that perimenopause has started?
And it is a vital question. Because perimenopause, which is that transitional phase leading up to the final finish line of menopause, it's an era of, well, profound hormonal chaos.
Chaos is the right word. I mean, it can begin in your early 40s or even your mid-30s and last a full decade.
Yeah, the medical literature characterizes this not as a gentle fading away of hormones, but as a period of intense, erratic fluctuations.
Okay, let's unpack this. Because to spot those very first signs, we have to look at the body's most obvious monthly rhythm, right? The menstrual cycle.
Right. But the earliest changes often completely contradict common sense.
They really do. You'd naturally assume that as the reproductive system winds down, the cycles would just stretch out.
Like you'd expect longer gaps, slower processes, things just, quietly fading to black.
Right. But the clinical data shows the exact opposite. A baseline 28-day cycle might suddenly shrink to 25 days, or even drop under 21 days.
Or the bleeding becomes significantly heavier.
Yeah. So instead of a car gently rolling to a stop because it's out of gas, the engine is revving wildly and unpredictably.
If we connect this to the bigger picture, the underlying mechanism driving that revving engine is a fundamental communication breakdown.
Between the brain and the ovaries, right?
Exactly. In the HPO axis, the hypothalamic pituitary ovarian axis, for decades, the brain and the ovaries have been in constant balanced communication.
But then early perimenopause hits.
Right. And the ovaries are running low on viable follicles. They become a bit less responsive, sluggish, basically.
And the brain notices this.
It does. The brain senses this sluggishness, specifically the lower baseline of estrogen, and it attempts to force the issue.
By yelling at the ovaries.
Pretty much. The pituitary gland pumps out a massive surge of follicle-stimulating hormone, or FSH. It's essentially screaming at the ovaries to produce a mature egg.
So the brain is slamming its foot on the accelerator because it thinks the engine is just stalling.
Precisely. And the ovaries, reacting to this massive surge of FSH, they hyper-respond.
They panic.
Basically, yeah. They might rush the maturation of an egg, releasing it much earlier in the cycle than usual.
Which is what drastically shortens the follicular phase of the month.
Right. And that's exactly why a cycle suddenly shrinks from 28 days to, say, 21 days.
And the heavier bleeding ties directly into this misfire too, doesn't it?
It does. Because the ovulation is becoming erratic, that delicate seesaw balance between estrogen and progesterone is totally broken.
So you have estrogen building up the endometrial lining aggressively.
But without a timely ovulation to produce, the progesterone needed to stabilize that lining.
Wow. So the resulting shedding is exceptionally heavy.
Exactly. Now, eventually, much later in the transition, the engine will stall out completely. That leads to cycles that skip 60 days or more.
But at the starting line, that compressed, shortened cycle is your primary diagnostic clue.
It is. Tracking your cycle isn't just a tool for family planning or avoiding pregnancy anymore.
Yeah, the guidelines make it really clear that your baseline data is your most powerful diagnostic asset.
If your cycle shifts consistently by 7 days or more, either shorter or longer, you're likely looking at the onset of perimenopause.
Regardless of whether you feel, quote unquote, too young for it?
Exactly. Because that HPO axis communication is breaking down, the resulting hormonal output becomes a daily roller coaster.
And since estrogen receptors are deeply embedded in virtually every tissue system in the female body, not just the reproductive organs.
The secondary signs of this chaos show up in highly unexpected places.
Here's where it gets really interesting, because I want to challenge a point in the research regarding those physical clues. Specifically, breast tenderness.
Ah, right. Nostalgia.
Yeah, because the baseline definition of this transition is ultimately ovarian failure and falling estrogen, right?
This is the overarching theme, yes.
But the medical sources, like the guidelines from Alloy and Health Central, they state that one of the earliest, most severe symptoms is swollen, painful breasts.
Right.
But biologically, severe breast tenderness is driven by high estrogen, like in early pregnancy. So how are the clinical guidelines reconciling high estrogen symptoms with a fundamentally low estrogen transition?
What's fascinating here is the biological paradox of the perimenopausal phase.
Yeah.
You aren't experiencing a clean, linear drop in hormones.
Right, it's that roller coaster again.
Exactly.
Yeah.
Because the brain is flooding the system with FSH to wake up those sluggish ovaries. The ovaries occasionally overcompensate.
So they don't just produce a normal amount of
They
estrogen.
pump out megadoses. Clinical measurements show that during early perimenopause, a woman's estrogen levels can spike significantly higher than they ever did during her peak reproductive years.
Wait, really?
Mhm.
Higher than her peak years? So you are dealing with literal estrogen dominance at the exact moment your overall ovarian reserve is depleting.
That is the paradox. And the key factor here is the lack of progesterone.
Because of the erratic ovulation.
Right. You often have anovulatory cycles where no egg is released at all, so the body doesn't form the corpus luteum.
Which is the structure that produces progesterone.
Exactly. And progesterone's job is to counteract and balance estrogen. Without it, you are left with what we call unopposed estrogen.
And this high, unchecked estrogen just aggressively stimulates the breast tissue and the milk ducts.
Causing intense swelling and pain. Nearly 40% of women report this severe tenderness.
I imagine it frequently triggers massive anxiety about breast cancer, too.
Oh, absolutely. But the literature notes this is typically a benign, functional pain driven entirely by the chaotic hormonal environment.
Now, because those hormone spikes are wreaking havoc on the breasts, it makes absolute sense that the subsequent crashes don't just leave the body unscathed either.
No, definitely not. When that massive unopposed estrogen wave finally recedes and plummets, it introduces a completely different systemic physical trauma.
Yeah, the medical literature has recently categorized this as the musculoskeletal syndrome of menopause. And it sounds brutal.
It is. Estrogen is deeply involved in collagen synthesis and the maintenance of synovial fluid.
Which is the biological lubricant inside your joints, right?
Right. Think of estrogen as the chemical scaffolding that holds water in your cartilage.
So when estrogen levels suddenly plummet during the downswings of the roller coaster, that scaffolding just collapses.
Exactly. The cartilage physically dehydrates and thins out.
Ouch.
Yeah. And at the same time, because estrogen is a natural immunomodulator that keeps systemic inflammation in check.
Its sudden absence triggers an inflammatory response.
Yes.
Which perfectly explains the data showing up to 70% of women experience sudden, unexplained joint stiffness, frozen shoulders, and deep muscle aches.
You go to bed feeling fine and wake up feeling like your physical structure has aged 2 decades overnight.
Your knees hurt walking downstairs, your hips throb. And because we are culturally conditioned to view menopause strictly as hot flashes and missed periods.
Patients end up sitting in a rheumatologist's office.
Exactly. Undergoing extensive testing for rheumatoid arthritis or lupus, completely unaware that their joint dehydration is a direct result of hormonal withdrawal.
And compounding that joint pain is the accelerated loss of muscle mass.
Oh, we're right.
The drop in estrogen affects muscle stem cell regulation, leading to a loss of up to 3 to 8% of muscle mass per decade after age 30.
So your joints are suddenly unlubricated and inflamed, and the muscular support system around those joints is concurrently weakening.
It's a structural perfect storm.
And that physical heaviness doesn't stay confined to the joints either. It permeates the entire physiological system.
Yeah, the medical breakdown from Care Fertility highlights this profound cellular-level exhaustion that sets in.
Women frequently describe this specific fatigue as feeling like they are wading through treacle.
I've heard that exact phrase so many times. It is an ongoing, crushing sense of physical and mental depletion.
The kind that isn't fixed by a good night's sleep or a cup of coffee.
No, And looking at the mechanisms, it makes sense, because the battery drain is happening at a molecular level with the mitochondria.
Okay, so it's like trying to run a high-end smartphone on a heavily degraded battery.
Exactly. Estrogen plays a critical role in regulating mitochondrial respiratory function.
The tiny power plants inside your cells.
Right. They are responsible for converting glucose into ATP, which is the actual molecular currency of energy your cells use to function.
So when estrogen fluctuates wildly, mitochondrial efficiency just drops.
The mitochondria simply cannot synthesize ATP at their normal capacity.
You're experiencing a literal, quantifiable drop in cellular energy output.
Your body is physically working much harder to produce less energy, meaning even minor physical or cognitive tasks leave you utterly depleted.
You have a degraded cellular battery. And to make matters worse, the biological charger is broken.
Because the perimenopause transition utterly demolishes sleep architecture.
Yeah, and the research shows this goes far deeper than just waking up from night sweats.
The temperature regulation issues, the vasomotor symptoms, they're highly disruptive, certainly. But the insomnia is rooted in neurotransmitter dysregulation.
This part blew my mind.
Yeah, so progesterone acts heavily on the GABA pathways in the brain. GABA is the primary inhibitory neurotransmitter. It promotes calm, relaxation, and sleep initiation.
But as erratic ovulation causes progesterone levels to flatline, that natural calming mechanism just vanishes.
Simultaneously, estrogen is deeply involved in the synthesis of serotonin.
Which in turn is a precursor to melatonin, your body's sleep signal.
Exactly. The entire chemical pathway that tells your central nervous system to power down is fractured.
So you end up lying awake at 3 a.m. Your body is exhausted from the lack of ATP, but your brain is completely wired because the melatonin and GABA signals are misfiring.
It's a nightmare. And this brings up a fascinating, highly specific treatment recommendation in the clinical guidelines.
Right. To combat this severe insomnia, the British Menopause Society explicitly recommends CBTI.
Cognitive behavioral therapy for insomnia, often alongside hormone replacement therapy.
But if you look at patient discussions like the expensive Reddit threads we reviewed on the subject, CBTI is frequently met with massive resistance.
And understandably so. When a patient reports severe hormonally driven insomnia and the doctor suggests therapy, it feels incredibly invalidating.
It sounds like the medical establishment is saying the insomnia is purely psychological or just anxiety.
But CBTI is not talk therapy.
No.
It is a rigorous behavioral conditioning protocol designed to physically retrain the brain's circadian rhythm.
It's about overriding the broken hormonal signals with brute biological force.
Precisely. Because the melatonin and GABA pathways are compromised by the hormonal chaos, CBTI uses strict sleep restriction.
To build up a massive homeostatic sleep drive.
An overwhelming biological sleep debt. This sleep debt eventually becomes so powerful that it essentially forces the brain to consolidate sleep, overpowering the erratic hormonal signals.
It's an incredibly grueling process to go through, limiting your time in bed to only a few hours a night initially. But the clinical efficacy for perimenopausal insomnia is remarkably high.
It really is.
Now, when you combine that mitochondrial energy deficit with a fractured circadian rhythm, you arrive at what is arguably the most terrifying early symptom for many women.
The cognitive impact.
The brain fog.
Yes. The sources indicate that 40 to 60% of midlife women report severe cognitive symptoms.
Forgetting common words, losing the thread of a conversation mid-sentence, severe working memory deficits.
The fear of early onset dementia during this phase is widespread and deeply distressing.
But looking at the neurology, the brain is highly dependent on estrogen for glucose metabolism.
So when estrogen levels are swinging wildly, the brain's fuel supply is unstable.
Right. And it is important to emphasize that the central nervous system is incredibly resilient. It will eventually adapt to a low estrogen environment once menopause is reached. So the cognitive dysfunction during perimenopause is primarily caused by the unpredictability of the hormones, not just the lack of them.
Exactly. The constant neural recalibration exhausts the brain. The fear of permanent cognitive decline is almost always unfounded. It's a temporary functional impairment caused by the transition.
Well, it all feels like a massive paradox. We have this chaotic hormonal roller coaster causing systemic debilitating issues, from shrinking cycles and severe breast pain to joint inflammation, cellular fatigue, and cognitive misfires.
Okay.
Yet, the clinical guidelines, specifically the NICE guidelines in the UK, explicitly tell doctors not to use blood tests to diagnose perimenopause in anyone over 45.
Right.
That goes against everything we're taught about modern diagnostic medicine. If you have a hormonal problem, why is the standard of care to refuse a hormone test? Why not just demand a blood test to be sure?
This raises an important question, and it is frequently the biggest point of friction between patients seeking answers and the medical system.
Because it seems so unscientific to just guess based on how you feel?
But because of the exact roller coaster dynamic we've been breaking down, a blood test for follicle-stimulating hormone or estrogen is a meaningless snapshot.
Oh, I see.
Hormone levels in early perimenopause can fluctuate wildly, not just day to day, but hour to hour.
Wow.
You could have your blood drawn on a Tuesday morning, and your estrogen levels might look perfectly robust, resembling a 30-year-old.
Have it drawn on a Thursday afternoon, and the labs might indicate full postmenopause.
So a single normal blood test result essentially gives a doctor false data.
Which often leads them to dismiss a patient's very real symptoms.
Exactly. Relying on lab values during a phase defined by extreme volatility is bad science.
So what do the guidelines dictate instead?
They dictate that the diagnosis must be purely clinical. It should be based entirely on the constellation of symptoms.
So the shifts in menstrual cycle length, the onset of vasomotor symptoms?
The unexplained joint pain, the insomnia, and the brain fog.
Yeah.
If a patient is over 45 and presenting with this clinical picture, the diagnosis is perimenopause. Period. The only exception where guidelines support blood testing is for patients under 40 or 45, specifically to rule out a distinct pathology called premature ovarian insufficiency.
Well, the takeaway for you, the listener, is fundamentally empowering. You do not need a piece of paper with a lab value to validate your physiological reality.
Knowing the actual mechanics behind the nAre and British Menopause Society guidelines allows you to advocate for yourself effectively.
Right. If a practitioner attempts to dismiss your joint pain or fatigue because a single hormone panel came back in range, you understand exactly why that panel is irrelevant.
You are the expert on your baseline, and you can demand symptom-based treatment.
Whether that involves hormone replacement therapy to stabilize the fluctuations, non-hormonal medications, or structured interventions like CBTI.
Knowledge fundamentally shifts the power dynamic in the clinic.
Absolutely.
Understanding that perimenopause is a clinical diagnosis protects you from the Tesla trap. It saves you time, money, and frustration, and gets you directly to targeted symptom management.
So what does this all mean? Let's quickly recap the biological realities we've explored today.
Sure.
The very first signs of perimenopause rarely look like the classic cultural stereotype of hot flashes and a sudden end to menstruation.
Instead, you're looking for the HPO axis misfiring.
Watch for your menstrual cycle compressing and shrinking under 25 days, or bleeding becoming heavier.
Be aware of the biological paradox where anovulatory cycles cause massive, unopposed estrogen spikes, leading to severe breast tenderness.
Pay attention to sudden, widespread joint aches and stiffness because your cartilage scaffolding is losing its chemical hydration.
And recognize that the crushing, wading through treacle fatigue and the terrifying brain fog are the direct results of compromised mitochondrial ATP production and neurotransmitter disruption.
This is a thoroughly documented, heavily researched systemic transition.
The erratic nature of the engine revving and stalling is the feature, not a bug.
You are not aging decades overnight, your joints aren't suddenly failing, and your cognitive slips are an adaptation phase, not a permanent decline.
Track your cycle shifts, document the systemic changes, and use that concrete data to navigate the medical system.
Which leaves us with one final provocative thought to ponder based on the underlying biology we've uncovered. We've detailed today how estrogen receptors aren't just located in the ovaries or the uterus.
They are ubiquitous.
Yeah, they regulate the mitochondria powering your cellular energy, they maintain the synovial fluid cushioning your joints, and they are deeply embedded in the sleep and glucose metabolism centers of your brain.
Estrogen is a foundational structural and chemical regulator for the entire female body.
Given this total body systemic impact, could the medical world's historical habit of treating menopause merely as a reproductive issue, a niche transition to be handled exclusively by a gynecologist, be one of the absolute biggest blind spots in the history of modern healthcare?
When you look at the sheer density of hormone receptors across the central nervous system and musculoskeletal system, isolating perimenopause to the reproductive organs is a profound failure of systemic biology.
It makes you wonder how much unnecessary suffering, misdiagnosis, and confusion happens simply because we keep looking at the sputtering engine and only checking the gas tank.
Completely ignoring the fact that the entire electrical grid of the body is hardwired into the exact same system.
Something for you to ponder until our next deep dive.